So up next, we're joined by Dr. Neal Shore, who will provide an advanced prostate cancer treatment update. But first, I want to say a quick thank you to our premier sponsor, Pfizer Oncology. I'd also like to thank our platinum sponsors, AstraZeneca, Bayer, and Johnson & Johnson. You can learn more about all of our sponsors in our sponsorship tab on the Summit website. As a reminder, if you have questions for our presenters today, and some of you have already submitted those, so thank you, but please submit those by emailing education@zerocancer.org, and we'll do our very best to get to as many questions as we can in our time period. And if you can, please be sure to include the session topic in the subject line of that email. That will really help us stay organized. So now we get to turn to Dr. Shore, who is here to provide our advanced prostate cancer treatment update. And with that, I will share my slides for Dr. Shore. So with that, Dr. Shore, I am thrilled that you're here. Thank you so much for making the time. Dr. Shore is at Carolina Urologic Research Center in South Carolina, and we're just thrilled that you are making the time to be here with us. So thank you so much, and I will go off video and give the floor to you.
Well, thank you very much, Shelby, and to all the folks at ZERO for doing all the great things that you do. It's just been such a pleasure and a privilege to be involved with ZERO now for almost 2 decades. The work that you do in educating patients and their families, providing inspiration for research and how we can better treat prostate cancer is really exceptional. And as you already said, it's really a great partnership to have not only with patients and families, of course, especially those who get involved in clinical trials, but the work that we do with, biopharma and the fact that they support, ZERO, a nonprofit organization, really dedicated to funding education and research for our prostate cancer patients. So this is how we make changes and how we improve what we're trying to do, which is to defeat cancer. So when Shelby asked me to talk about this, it's a real pleasure for me because I've had the great privilege to be involved in lots of different studies along the way that have led to changes in how we treat prostate cancer. And we were talking, way beforehand about this program tonight. And so I said, well, why don't I just try to give an overview of the really significant changes that have occurred from the earliest portion of the disease, particularly the high risk localized, and then extend that and go all the way through to the more advanced cases, or what we call the MCRPC. And additionally, talk about some of the really cutting edge things regarding evaluation for treatment response, and that's in the form of biomarkers, the importance of genetic testing, which can influence a lot of aspects to prostate cancer, approved therapies that are genetic marker specific, talk more about that, and clinical trials work, and impact on family members for not just prostate cancer, but other cancers, as well as the really exciting field of imaging and how that has changed and continues to change. And if we have some time, we'll just talk about some clinical trials that, we may see important readouts in the next, 12 to 24 months. And clinical trials are really important because it's through clinical trials, successful clinical trials, that we're able to change our armamentarium, or add tools to our tool belt or toolbox, and change clinical practice. We do clinical trials to change clinical practice, to make it better, to give patients more options. And throughout the continuum of prostate cancer, I always talk to patients about what I call 4 Ps, and in no particular order because everybody's different. But I talk about what a lot of physicians tend to focus on is prolonging survival if we can't cure the disease. And that would be particularly true in patients who have what we describe as, metastatic disease or advanced disease beyond the prostate. So first P, prolonged survival. And oftentimes patients will say, well, what does that mean? I say, well, maybe we can't cure you, but I want to try to make the disease, prostate cancer specifically, as chronic as possible. Maybe in some ways it's like thinking about having chronic, non-oncologic process like diabetes or high cholesterol or hypertension. So they don't want you to die of the cancer. But it's not just living and dying. We want to, maintain a really good quality of life, as that vernacular goes. And so that's the second P, preserving the quality of life. And quality of life differs for everybody. It can mean, running a marathon. It can mean traveling. It can mean fishing. It can mean gardening. It's a lot of different things, and that's pretty subjective, but it's extremely important, one's quality of life. Maybe it's just, visiting one's children or grandchildren, or playing, tennis or golf or pickleball, but being able to do that. Third P is preventing complications of therapy. There's, unfortunately, most therapies, there's as they say, there's no free lunch. There are going to be side effects or adverse reaction profiles. It's very important that whoever your physician is, radiation oncologist, medical oncologist, uro-oncologist, nuclear medicine radiologist, your primary care physician, your nurse practitioner, your physician assistant, that you have a really full-throated conversation about what the safety and side effects, tolerability are of therapies, so we can prevent complications. And the fourth P, I think, is really important. I think it doesn't get as much attention formally in our educational systems, and that's a preference value. And by preference value, I mean, how risk averse or risk seeking are you? And I first learned about this where I taught a course when I was at a Duke senior. I majored, one of my majors at Duke and undergraduate was public policy studies. And I was a graduate student. Actually, I was in my first year of med school, and I was helping out there with, as a teachers or TA, they call it, or sort of help the professor. And the name of the course was Analytical Decision Making for Busy Decision Makers. And that's where I learned about this concept. And I think it's very important, of preference value. And another way of thinking about that is, on the spectrum of making a decision about your cancer care, are you incredibly risk averse, or are you, incredibly risk seeking? I think most people are somewhere in between that. Risk averse would mean, look, I don't want to do anything. I don't want to go to the doctor's office. I don't want to get any treatments. I'm just going to roll the dice and see where I go. That would be extreme example of risk aversion. And a risk seeker would say, look, I want everything you can do for me at any point in time. Tell me what I can do. And is it one therapy? Is it two therapies? Is it an oral or an intravenous or an injection under the skin or in the muscle? I want whatever you can give me, as well as let me know what clinical studies you have. So again, 4 Ps: prolong survival, prevent complications, preserve quality of life, and preference value. And I think that's all subsumed under the importance of what's called shared decision making, that the patient and his partner, family, friends make the decision. We've sort of moved away from the physician in this kind of paternalistic thing where the doctor says, this is what you should do, must do, I'm going to tell you. And I think shared decision making is really important because then there are no wrong decisions. They're the decisions that's right for you. Okay, let's get a little bit more granular and talk about what's happened in these different subjects. And I'm just going to go through them. And so for high-risk localized prostate cancer, I'm just going to give you some pearls, some nuggets. When we say high-risk localized, there is always some differences amongst whose guidelines you're talking about. But when we've now said, when we get a biopsy and you get a Gleason score, it really is pretty standard of care now to use the Gleason grade group, which was harmonized internationally by the International Society of Uropathology, ISUP. So you're a 1, 2, 3, 4, or a 5, depending upon the highest number of your Gleason grade group pathology report on any one of the cores that were taken. Now that just assumes that you have a histopathologist who is good in prostate cancer. If you're not sure about that, it's not unreasonable to ask for a second opinion on your pathology. But if you're a grade group 3, 4, or 5, that starts with unfavorable intermediate risk. That's a 3. 4s and 5s are high risk. What we know historically is whether, and if your workup doesn't show any disease outside the prostate, and I'm going to get to what workup, how that's changed too. But if your evaluation with imaging doesn't show any disease outside the prostate, and you're a grade group 4 or 5, and even arguably a grade group 3 with a very high PSA score, you're a good candidate for something to do an active interventional treatment. So remove the prostate, prostatectomy, or radiation therapy. And that'd be radiation therapy with typically that would involve some duration of hormone suppression or testosterone suppression, also known as androgen deprivation therapy. Well, in our high-risk patients, we had a trial that came out now almost 2 years now, and it was done in the UK largely, where we had patients who and in Europe as well, where patients received radiation therapy for grade group 4 or 5 disease, Gleason 8s, 9s, and 10s, Gleason grade group 3, so Gleason 7 unfavorable, which is the 4 plus 3, as opposed to the favorable intermediate 3 plus 4 with very high PSAs. And the bottom line of this particular study for getting radiation to the prostate with 2 years of androgen deprivation therapy, so injections to lower the male hormone, by adding a drug called abiraterone acetate plus prednisone, these patients had delay in progression and also had improvement in survival. And so now this has been incorporated into our guidelines, NCCN, the National Comprehensive Cancer Network, and pretty much all the international guidelines. So this was a real big advance because 25 to 50% of patients with high-risk localized disease will not be cured with radiation or with surgery. And that's why we've now added to the hormone suppression abiraterone acetate and prednisone. I'll just jump to the very bottom and tell you that there's 3 additional trials that are essentially mirroring, not entirely, but close to mirroring this trial that I've just alluded to, which is known as the Peace 1 trial. And they're using, instead of abiraterone acetate, they're using in 3 different trials apalutamide, radiation hormone suppression, in another trial enzalutamide, radiation hormone suppression, and in another trial darolutamide, radiation and hormone suppression. I think everybody is very optimistic about these studies, but the first trial with abiraterone is the only one that's read out and had clearly had a positive impact and has changed the guidelines. We don't have anything yet with surgical intervention, although there is an important study, phase 3 trial, high-risk patients known as Proteus or Proteus, and that's getting high-risk patients who choose surgical removal of the prostate, 6 months of therapy before the prostate's removed with apalutamide and hormone suppression, androgen deprivation therapy, surgery, and then another 6 months of that same therapy to follow. The control arm there will get hormone therapy with, actually the control arm there will just get standard treatment. That's an important study. We actually have a trial that will be presenting a phase 2 study in high-risk patients who underwent prostate removal, prostatectomy, and who received 12 months right afterwards of hormone suppression, a combination of androgen deprivation therapy and apalutamide. We're going to be presenting the data, the 2-year follow-up data after they completed surgery, a year after they stopped the hormone therapy. It hasn't been presented yet, and it will be presented for the first time at the AUA at the end of April in San Antonio. So I would stay tuned for that report. Then let's move to biochemical recurrence. I'm really proud of the trial that I was a co-PI on globally, and that was the EMBARK trial. Very simply, the EMBARK trial took patients who had either surgery for localized prostate cancer or radiation for localized prostate cancer, or both, surgery followed by radiation. And they were in that 25 to 50% group that had a PSA return. And we oftentimes call that biochemical recurrence, PSA relapse for all practical purposes. And we started that study about 9 years ago. It was a global study. And we randomized patients who had the biochemical recurrence to either receiving traditional LHRH alone and a placebo, or LHRH androgen deprivation therapy plus enzalutamide, 160 milligrams daily, and a third arm that just got 160 milligrams of the oral enzalutamide. As you probably know, enzalutamide has been, in combination with androgen deprivation therapy, has been approved throughout the spectrum of prostate cancer, except in high-risk localized disease, and there's been no approvals for any of the androgen receptor targeted agents or in the androgen receptor pathway inhibitors for biochemical recurrence. Outside of the United States, there's an approval in some countries for 150 milligrams of bicalutamide, which is one of the earliest generation androgen receptor blockers, not approved in the US because of no level 1 evidence for its benefit in biochemical recurrence, and also some concerns regarding its safety profile. But I'll just jump to the conclusion that we presented at last year and then had a New England publication. For patients who had a really fast doubling time of 9 months or less, which has to be calculated, which was an inclusion requirement for the EMBARK trial, the combination of enzalutamide with LHRH therapy bested LHRH alone, and likewise, enzalutamide oral monotherapy bested LHRH therapy alone. The endpoint of the study, using what's called conventional imaging, traditional imaging, full body CT scan, and bone scan with the tracer technetium, which was done at baseline, and then every several months for literally 9 years with regular PSA checks. The endpoint was what we call metastasis-free survival, which was largely radiographic progression. And ultimately, what we showed again was highly statistically significant p-values or demonstration that combination LHRH and enzalutamide bested LHRH alone, as well as enzalutamide besting LHRH alone. That means that there's a delay in prostate cancer radiographic progression, a delay in the increase in the PSA, delay in the onset to developing resistant disease, going from sensitive to resistant, delays in pain progression, delays in requiring another therapy. And so the FDA looked at that information that we presented at the end of April, and on November 16th, 2023, did a label expansion for patients who have what's called high-risk BCR, PSA recurrence, after surgical removal of the prostate or radiation, or even both. And now you have options. This is the first time we completed a phase 3 global prospective blinded study demonstrating that there's superiority of combination ENZA and LHRH over LHRH alone, and superiority of enzalutamide over LHRH alone. Now, there's different side effect profiles. Because when you look at the combination ENZA LHRH versus the ENZA alone, and I think it's important when you talk to your physicians to make sure you have a real careful conversation about what those differences are. But it's really great that this now, at least for our U.S. patients with FDA approval now, and I just think it's so important because this just happened only a short while ago. It just gives patients and their families some additional options. So that's really the most recent approval change. But let me talk about some really important things now for our patients with metastatic hormone-sensitive prostate cancer. Oh, and by the way, I don't know that that trial took us essentially almost 9 years to complete. Now, one of the things that's interesting about it, we did it with all that conventional traditional imaging. Let me maybe jump a little bit to the bottom where you see the name advanced imaging. In the last couple of years, we have had the approval now of new PET scan technology called PSMA PETs. And PSMA is not PSA. PSMA stands for prostate-specific membrane antigen. It's totally different from prostate-specific antigen. And it's an antigen, it has what's called intracellular and extracellular components, and that becomes important in a reason I'll tell you in a second. But with using different radiopharmaceutical tracers, we use gallium in the US and fluorinated or fluor 18F. It picks up, detects on imaging with PET technology more accurately traditional CT scan and bone scan. Probably its best use, my opinion, is in patients who have high-risk localized disease and biochemical recurrence, because these are patients who traditionally we wouldn't see where is prostate cancer cells in the case of high-risk localized and they're at risk. Is it in the lymph nodes in the pelvis, outside the pelvis, maybe even in bone, occasionally in lung and liver? That would be viscera. And likewise for the BCR, biochemical recurrence patients. And so if you get that information, well, what do you do with that information when conventional imaging is negative? Well, we're doing a lot of clinical trials now to try to see where is the utility. But one of the things that often gets talked about is doing spot focal radiation to sites. Maybe that can delay the use of systemic therapies. It's still controversial. There's a lot of debate. We need more trials to get done, but it's exciting to recognize that it's opening up new trials and new ways of treating the cancer if we have more accurate imaging studies. And I think most would agree. Certainly our colleagues in nuclear medicine radiology have done a great job. The European Association of Nuclear Medicine, EANM, and the Society of Nuclear Molecular Imaging in the United States, SNMMI. But let me just kind of transition over now to MHSPC. MHSPC, which is, unfortunately, you'd present not with localized disease, but metastatic. That's what the M stands for. And that would be disease based upon the imaging that's nodal tissue in the pelvis, above the pelvis, in the retroperitoneum, maybe in the chest, the mediastinum. Visceral disease, which is typically referred to as longer liver disease, and of course, bone. Prostate cancer, more than any other solid tumor cancer, likes to go to the bone. We're still trying to understand all the reasons for it, but that's a very common phenomenon. The bottom line is whether you have a lot of disease, many bone lesions, 4 or more, or disease in the lung or liver, which would be, we tend to call that high volume disease, or even if you have low volume disease, just lymph nodes or maybe 3 or less bone lesions, no disease in the lung or liver, we tend to refer to that as low volume MHSPC. Regardless of whether you have low or high volume disease, the bottom line is that just giving androgen deprivation therapy, whether that's with an agonist or an antagonist being an injectable or an oral, because there is now an oral GnRH antagonist that's been available now for a couple of years, which a lot of patients find important in the discussion because it's take a pill once a day versus an injection. But either way, monotherapy or single therapy androgen deprivation therapy is essentially no longer the standard of care, because we've had multiple studies, 8 or 10 now, depending upon how you look at them, demonstrating that when you combine a androgen deprivation therapy with an oral agent that blocks the androgen receptor, inhibits it, whether it's abiraterone acetate, apalutamide, or enzalutamide, these trials, big phase 3 trials, demonstrated the superiority to delaying progression and improving survival compared to just getting hormone suppression, androgen deprivation therapy alone. And here's something I'm going to tell you that you may find shocking and disappointing, but still some data suggests that upwards of 50% of men in the United States are still only receiving monotherapy ADT when it's no longer the standard of care for MHSPC. Full stop. Full stop. It's in virtually every guideline across the world. And in addition to just getting the 2 therapies, the androgen deprivation therapy and an oral agent that would block the androgen receptor, there have been 2 major trials that have demonstrated that by adding docetaxel chemotherapy for 6 cycles, so an androgen deprivation therapy, 6 cycles of a chemotherapy known as docetaxel, plus an oral agent that blocks the androgen receptor, will also dramatically improve versus just getting androgen deprivation therapy and the chemo alone. And that triplet trial were done separately, one with darolutamide, and another one that was done with abiraterone. So I particularly recommend that to my patients with high volume disease who are clearly good candidates for chemotherapy. But it's one of those shared decision-making conversations. Getting back to someone's preference value, I think it's very important. But monotherapy ADT is no longer the standard of care. There will be 2 important trials that will read out this year, looking at ADT plus darolutamide without chemotherapy, much like other trials looked at ADT plus apalutamide or ADT plus enzalutamide or ADT plus abiraterone. And the ADT darolutamide going against single therapy ADT will read out this year in a big global trial, and then a large phase 2 study of 200 patients just looking at ADT and darolutamide will also read out in US patients this year with using a control of the monotherapy ADT arm from an older trial known as the Charted study. So I'm very, I'm cautiously, but actually very optimistic that that'll read out this year and hopefully will give us an additional option for MHSPC. When it comes to NMCRPC, we've had 3 blockbuster studies based upon conventional imaging. When the PSA starts to go up, the testosterone's suppressed. Conventional imaging doesn't show any disease in the lymph nodes, the viscera, or the bones. And 3 really excellent studies known as Spartan, Prosper, and Aramis, which looked at apalutamide, enzalutamide, and darolutamide for these patients being evaluated with conventional imaging. And these were all 3 very successful studies that bested monotherapy ADT alone, delaying progression and improving survival in all 3 of those studies. Now, those were also done with conventional imaging. Newer PSMA PET, probably about 90+% of the time, will show disease, but most people would argue that it wouldn't really change what you'd offer the patient. There may be some exceptions to that, but I don't know that we have to go into that at this point. But it's important to know that we made real advances, in the last few years with that group. Now, the metastatic CRPC, the castration-resistant, which means your disease is progressing despite testosterone levels being suppressed with therapies or surgical, removal of the testes. That word castration is a very harsh word. No one really likes it for obvious reasons. There's always a lot of debate about trying to change it. And we talk about the importance of nomenclature. But one thing that's really, happened is is testing. And I mean by that is genetic testing. And unfortunately, within the community of US urology and even US medical oncology, we're still not testing our patients enough who have either high-risk localized disease, BCR, any metastatic disease. All of these patients should be receiving forms of genetic testing. There's 2 forms of genetic testing. One is called germline testing. It's really simple. It could be either a blood test or a saliva swab. And it was several thousands of dollars years ago. It's now been markedly reduced to only a couple of $100 and sometimes even less than that. So that's the good news. What is germline testing? Simplistically stated, it looks at genetic alterations that you could have inherited from either your mother or father. When the egg and the sperm, the ovum and the sperm combine, you get half of your genetic complement from your mother, half from your father, and they can pass along genetic alterations. The most common one that folks are familiar with is called the breast cancer gene alteration, or BRCA. Some people say BRCA. But there are a lot of other genetic alterations. One goes into this family of called homologous recombinant repair alterations. And without getting too much into the details of the weeds of that, you can also find genetic alterations that you didn't inherit from your mother or father, though that would be non-germline, or the other way we really say it is from the tumor. And another word we use just to confuse everybody is we say somatic, which means the tumor for all practical purposes. And you can get the tumor tissue, whether it was the original biopsy, or you can get tissue that from retrieved from an interventional radiology biopsy of a lymph node. or a lesion in the liver or even in the lung and occasionally even in the bone. And you can find genetic alterations in the tumor tissue itself. Now, if you can't get the tumor tissue from old samples or a new biopsy, you can do blood tests called circulating tumor DNA, or some people call that a liquid biopsy. So why does that matter? Well, we now have a whole class of drugs called PARP inhibitors that are specific as when they're given by themselves, oral therapy given alone to treat patients who have specific homologous recombinant repair, HRR genetic alterations. The most prevalent of those gene alterations is the BRCA, the BRCA. So unfortunately, we're still under testing, and I don't think we're doing a lot of under testing in our tertiary or academic centers. I've been getting combined germline and somatic testing on virtually all of my patients in the last 8 years, and we're actually trying to even promote the democratization or universal germline testing in all prostate cancer patients, much like we do with breast and ovarian, colorectal patients. Right now, you get germline for virtually every prostate cancer patient, unless you're grade group 1, 2 when on your first biopsy. So Gleason 6 or 3 plus 4, 7, and no family history of cancer. The problem with that is that a lot of folks just don't know their family history of cancer. And so we've published papers, and we're trying to get different guidelines folks to just universalize it. That way everybody gets tested. Plus, I already told you how the cost has come down dramatically. Somatic testing is more expensive. I think it's fair to say that everyone recommends it if you have resistant disease and you're metastatic. Most of us, I think, are getting it when you're metastatic with sensitive disease, because you want to know early on in your toolbox what treatments you have available, and then also for clinical trials. So in the last year, there were 3 really important studies that got published, and it changed the guidelines and FDA approvals. One looked at combining a PARP inhibitor called olaparib with abiraterone acetate for patients in first line or frontline MCRPC. Another one was called it was another trial, but a different PARP inhibitor, niraparib with abiraterone acetate, and a third trial combining enzalutamide with a PARP inhibitor known as talazoparib. All 3 of these trials were successful, and all 3 received approval by the FDA in May, June, and August of this year. So if you're a frontline patient with MCRPC and you've only had monotherapy ADT, there's an approval for combining a PARP inhibitor with a androgen receptor, a targeted agent. Now, there are differences amongst these studies in terms of the panel of genes approved. The talazoparib enzalutamide has a 12-gene panel. The abiraterone and olaparib, the niraparib and abiraterone are just for BRCA in the United States. It's different outside the United States. There's broader approval for olaparib and abiraterone in Europe. So a lot of this, though, it still begs the question, why are we underutilizing genetic testing? And part of it, I think, is we need to do a better job amongst our healthcare providers to educate them, as well as patient advocates and patients to become more knowledgeable that you want to get this testing. Importantly, if you have a germline, let's say you have a germline BRCA, and you've got prostate cancer, well, you really have to inform your children, your siblings, your nieces and nephews, because that increases their risk of not just prostate cancer, but also breast cancer, ovarian cancer, potentially colorectal cancer, upper tract cancers of in the urothelium, in the pelvic calyceal system. pancreatic cancer. And wouldn't it be great to have one of your family members find their cancer really early, ovarian, especially pancreatic, so they can be cured? And like I said, with the somatic testing, if the germline's negative, you don't stop with that. You get the somatic testing because it's unrelated to what you receive from your parents, and you may find genetic alterations which have led to FDA approval, Medicare coverage for these drugs by themselves or in combination. And there's even other approvals for alterations known as tumor mutation burden high and microsatellite instability high. I'm not expecting folks to remember these names or these acronyms, but know that there are specific drugs that have been approved for the latter that I just talked about that would be an immunotherapy. So we've got to do greater education regarding testing. I talked about imaging. These are really important things. And just kind of getting back to biomarkers in general. I usually talk to patients, they say, well, how long am I going to be on this treatment? I say, well, I think it's really kind of true for virtually all solid tumors is we're going to, look at your lab work, depending upon the biomarker. I think it's prostate cancer, the CBC, the complete metabolic profile, LDH, circulating tumor DNA. That's a really good example of, are you responding to therapy or not? The timing for getting it and the frequency is still being debated, but at least it's out there. And this allows us to help decide is the treatment working or not. So lab work, imaging, follow-up scans, and then subjectively, how are you doing? So those three things, the three things of a three-legged stool, are regular conversations that I have with my patients, and I think oncologists and uro-oncologists and radiation oncologists do the same. There are going to be some. We talked about some of the trials that are reading out in high-risk localized, and in some MCRPC studies. We just had a recent readout of another drug that was being studied, was a CDK4/6 inhibitor approved in breast cancer called abemaciclib, and it was a study, Cyclone 2 and MCRPC. Unfortunately, it didn't have a positive readout. The data hasn't been presented or published yet, but that was disappointing. So not every study has a positive readout, but many of them do. In 2004, we had one life-prolonging therapy for prostate cancer. That was docetaxel. Here we are 20 years later, and we have 12. So we've gone from 1 to 12. I think that's really good. In addition to the improvements in imaging and genetic testing. So I'm incredibly excited about what we've been able to accomplish and some of the really wonderful things that are moving forward. Of course, I didn't even touch on it yet. I'll just say a word briefly on it, is radioligand therapy. That's where we are able to do a conjugate between a radiopharmaceutical and tie it into a antibody that targets the prostate-specific membrane antigen. And we have beta pharmaceuticals known as lutetium approved in MCRPC for patients who progressed after receiving a taxane, a chemotherapeutic, as well as an androgen receptor targeted agent. We're looking at many trials now prior to chemotherapy. And in addition to the radiopharmaceuticals known as beta particles, we'll be investigating alpha particles. A popular one that people talk about or commonly describe one is known as actinium. We also already have had for many years, over a decade now, the use of an alpha particle known as radiopharmaceutical of radium, which is really also now being investigated in combination with enzalutamide in a large trial known as PEACE 3, We should get that readout sometime this year. That's really exciting data that's pending, which may lead to us investigating radium-223 for MHSPC patients. But so the world of radiopharmaceuticals is here, in addition to many of the other therapies that I talked about earlier. So let me stop for purposes of time and take some questions.
We do have a few questions that have come in, so let me just get to those. So one question that was submitted actually prior to the session came in from a patient wondering what are the requirements to enable someone with stage 4B with bone mets to go on intermittent ADT?
So the whole concept of de-escalation, intensification, right? We're intensifying with our MHSPC patients. And I said, monotherapy is no longer the standard of care, but you should be adding an androgen receptor targeted agent, and sometimes also adding a short course of chemotherapy in the form of docetaxel.
Mm-hmm.
But as I said, there's no free lunch. And so if you get a really deep response, how do we define deep? Maybe you had PSAs in the hundreds, maybe even in the thousands, and you got it down to something less than 1, even hopefully down to the undetectable level. And you're getting a lot of side effects, and you're suffering from the side effects of T suppression and arguably AR blockade. And you're getting a great response. Biochemically, your labs are all looking really good. And from an imaging standpoint, you're seeing a lot of regression, or certainly at the very least stabilization, no new lesions. It's a discussion that there are many, physicians, uro-oncologists, medical oncologists, who would say if the patient's having a lot of side effects, being really bothered, that they could consider a treatment holiday, an interruption. I have had many very esteemed colleagues who are like, really, please don't, they'll say, don't do that. Don't want to give the clones of the cancer cells some time to find a way to recur. I take a more nuanced approach. I don't say one versus the other. I think it's really important to have that conversation with the patient and his support team. I'm not against de-intensification. If I can offer a holiday, we're not saying go become like an ostrich and stick your head in the sand. We're going to check your lab work within a couple of months, 2-3 months, and see how you're doing. Repeat the PSA, maybe look at some other other markers in the bloodstream, see how you're feeling. I tend to like holidays. I think, patients really like it, makes them, feel like they're kind of getting their life back.
Yeah, right.
So I think that's really important. Very, very, but it's important. It's part of the art of medicine and individualizing.
Yeah, absolutely. One of the best quotes I ever heard from a doctor was, "I'm really good at my job, but it's about 50% science and about 50% art." So I love that. So we have a question that also came in from someone who is currently on standard of care for advanced disease. This person does have bone metastases and is, very aware. I'm just kind of paraphrasing here. I know this is not a cure, but I am also told that, the median survival is 3 to 5 years. So this person's wondering, where is the best place online to just get the latest details about breakthrough treatments that may, like you said, are kind of coming, these new readouts, especially the ones that you're really excited about?
Yeah, that's a very good question. I tell patients several different sources. At clinicaltrials.gov is a very good resource for picking up really where clinical trials are from early phase to phase 3s. it just tells you, usually what the trial design is, and offers you like where you can find the trial sites. In terms of the newest treatments that are out there, I really like the Prostate Cancer Foundation, PCF.org. You will pretty much update regularly and in patient-friendly language. Of course, Zero's website is great in updating on a pretty regular basis. The NCCN, as opposed to ASCO, American Society of Clinical Oncology, and the AUA, and ASTRO, American Society for Radiation Oncology, and even the SUO, Society of Urologic Oncology, the NCCN is pretty good in updating approvals of newest information. Some of the challenges with the NCCN, though, is they give you like this, big menu, and it can be a little confusing. So I think where do you get trusted information these days? This word trust and who's authentic. Yeah, I mean, Zero's website, NCCN, Prostate Cancer Foundation, clinicaltrials.gov for prostate is really good. A lot of folks, clinical practices, as well as the tertiary academic centers, they have good information. Honestly, sometimes I think it's overly self-promoting sometimes. And so you have to have a little bit of a jaundiced eye as when you look at that. So those would be my recommendations.
Yeah, absolutely. And several areas on the Zero website link to all of those organizations and scientific meetings. So yeah, absolutely agree. Love that. Have time, excuse me, for one final question. This person is wondering about Pluvicto. This patient is on round 2, and I think was expecting to see some better, quicker improvement at this point, and was wondering if there are any statistics or papers that show how, on average, how quickly or effective that treatment can be. Can you speak to that?
Sure. So that's the lutetium-617. And we were actually, my site at Carolina Urologic Research Center, I was really proud of this, that there was no urology community-based site that enrolled more patients globally in that trial than we did.
Wow.
We've also participated, and that led to FDA approval of lutetium-617. The commercial name is Pluvicto in the United States. And theoretically, the approval is for patients with mCRPC progressing, as they did in the trial, after at least one androgen receptor targeted therapy and at least one taxane. Many of the patients had more than one ARTA and more than one taxane. We just completed 2 studies where we looked at pre-chemotherapy mCRPC patients getting lutetium-617. That was the PSMA-4 trial, and another trial known as the SPLASH trial, where they received lutetium, a slightly different version of the 617, what's known as the INT, imaging and treat, or imaging and therapeutic. But neither one of those trials have published their results yet. They were statistically significant in terms of delaying progression. Those patients are being followed for survival benefit. That hasn't been published yet. So those patients are still being followed. Not everybody, responds. Not patients, in order to get the lutetium-617, have to have a PSMA PET that is positive. In the Vision trial, 87% of patients did have a PSMA PET that was positive. I think that patients do particularly well who are primarily a lot of lymph node disease, some bone. The patients with liver disease can respond, don't always do as well as those with just lymph node only and or with bone disease. So we're still debating how closely how do we follow those patients. In addition, we do see good PSA responses in many, but not all. We do follow these patients now. We're debating when to get the next PSMA PET scan. And so we're learning as we go along. The drug was approved for 6 cycles, once every 6 weeks for 6 cycles. Some patients may respond faster. Some may not respond in their entirety based upon maybe their tumor burdens and also their level of what's called, the SUV, or the standard uptake value. I don't want to get too complicated, but we're learning still with lutetium, and we're going to learn more with other products. And it's an exciting area. It's an important area. Unfortunately, not everyone responds, and some patients can respond, remarkably robustly.
Yeah.
And so it's important to continue to have these conversations with your physicians who are providing the therapy. We presented a poster at ASCO GU where upwards of 40% of patients in the US who are getting lutetium-617 did not actually progress after getting docetaxel therapy. So just sort of interesting to see how some of the patients are getting the treatment. And that was at ASCO GU 2024 this year.
Yeah.
In a poster that we presented. Yeah.
Great. Excellent. Well, thank you so much, Dr. Shore. I'm thrilled that you could take the time out of your very busy schedule to join us for the very first day of our virtual Zero Prostate Cancer Education and Support Summit. So you really helped us kick off day one with a bang. So really appreciate you.
My pleasure. Thanks for inviting me.
You're very welcome.